I'll talk about the small technique, quantitative correction of the atlantoaxial dislocation with baseline variation, especially focused on the importance of axial tilt, not the craniovertebral junction angle. I have no disclosures. As you all know, and nowadays the treatment of baseline variation and atlantoaxial dislocation, the first option should be correction of the dislocation by either posterior or anterior approach. And recently, we published a strategy for the treatment of baseline variation and atlantoaxial dislocation, except for the fixed dislocation with C1C bony fusion. We always try to reduce the dislocation by direct posterior approach. Additionally, after surgery, we always evaluate the patient using MRI imaging, but not only the CT scan. Using MRI to see if the dislocation, if the decompression is complete or not. For this is an example. A patient of 11-year-old boy with a typical baseline variation and atlantoaxial dislocation and with a spinal cord compression. This is post-operative CT. It seems not good, not a perfect reduction of the dislocation. But if you see the MRI, we can see here a good, very good and radical decompression of the spinal cord was achieved. So for this patient, what we could do is only the follow-up of the patient, but not any other treatment is needed. But if we see this patient, this is the post-operative CT. We can see the reduction. It seems is very good reduction, and also from the MRI, there is a complete decompression of the spinal cord. But if we see the subaxial segment of the spine, with time, the patient developed subaxial kyphosis. So what's the reason? So this is a question I'd like to focus today: how to perform the sagittal alignment, both in local region and the subaxial cervical spine. Because if we correct atlantoaxial dislocation in a lordotic position, or the overlordosis of the cervical spine will cause the damage of quality of life. And in some patients with dysphagia, even dyspnea in very rare conditions immediately after the extubation. If the patient develops kyphosis post-operatively, the patient also will have neck pain. Recently, the study is showing that if the alignment is not good, the subaxial disc degeneration will occur. In this study, the authors measured the intradisc pressure after C1-C2 fixation. They found that significant intradisc pressure increases at the subaxial segments after C1-C2 fixation during the flexion extension. So as we all know, the change of C1-C2 angle will be correlated with the change of C2, C7 curve angle. So recently we published a further study by a simple geometric method. We can deduce that the change of cranioaxial angle, that means CXA, equals to the change of C2, C7 curve angle. Now, of course, we suppose that the C1 slope is relatively constant during atlantoaxial dislocation surgery. And the sagittal alignment of the spine, as we know, always tries to keep the horizontal gaze. We can measure the horizontal gaze using the Frankfurt horizontal line. So this formula can be deduced geometrically. Now this is a confirmation. We confirmed using 16 cases, this formula. This is the example. The change of clival axial angulation equals to the C2, C7 corpus angle. But the question still remains, how many degrees of clival axial angle should be corrected in patients of orthodontoidum? Of course, we can correct this angle to 160 degrees as the value of normal individual. But what about for the patient of baseline variation? Because there's a congenital anomaly. Is always the 160 degrees? Is random? So we did recently did a further study, and we divided the CXA into two parts by the Chamberlain's line, or a line parallel to the Chamberlain's line. So the upper part we named that clival tilt, composed by clivus and the Chamberlain's line. Anatomically, this angle is fixed. And the lower part, composed by Chamberlain's line and axial line, is mobile. We call this angle the axial tilt. We measured 23 normal individual and 42 baseline patients, including among them 32 patients had also atlantoaxial dislocation, and we found that not only the axial tilt, but also clival tilt have a great difference to that of normal group, normal control patient. So in the baseline variation patient, the CXA is about 130 degrees, and the normal individual is about 116, as we are known in the normal individual. So this is the point. If correction of CXA to 160 degrees means overcorrection of atlantoaxial overcorrection of axial tilt, because as I said, the clival tilt is fixed, is anatomically fixed, and consequently loss of lordosis or kyphosis was subaxial cervical spine. So what we should do is to correction of axial tilt to its normal value, about 94 degrees, but not clival axial angle. So take this patient as an example. Now the CXA is about 100 degrees, and the 80 is about 55 degrees. So what we should correct is only 39 degrees of axial tilt. So the final CXA should be 139 degrees, but not 160 degrees. If we correct the patient to 160 degrees, that means overcorrection of AT. So this is an example from the literature published in European Spine. The patient had a 101 degree clever axial angle before the surgery. After surgery is about 157 degree postoperatively. So we can see with time the patient developed kyphosis, cervical spine kyphosis. So this is a typical example of overcorrection of the overcorrection of axial tilt. So this study suppose that the T1 slope is relatively constant during atlantoaxial dislocation surgery. Actually, T1 slope is defined by thoracic and thoracic lumbar alignment. So this is a typical literature published in WFNS Spine. And the cervical lordosis, this is a relationship of cervical lordosis and T1 slope. That is about 15 degrees. In a recent study, they further indicated that the cervical lordosis equals to T1 slope minus about 16.5 degrees. And this formula implies that kyphotic cervical alignment is to be expected for individuals with a T1 slope less than 16.5. So let's take this patient example too. If we, based on our, the measurement I mentioned before, we can correct the patient directly. We correct only the AT, the axial tilt, from 55 degrees to 94 degrees. That means we have to correct 39 degrees of the axial tilt. And the final CXA should be 139 degrees. The cervical lordosis will be 11 degrees. Now, if we based on T1 slope, let's see, and calculate the subsequent angles of the cervical lordosis, the change of cervical lordosis should be 39.5, more or less similar to the axial tilt change. So it seems both methods is rational and correspondent. So we think that T1 slope is also a very important modifier in some specific patients. Of course, the baseline variation is much more complicated rather than only a simple sagittal imbalance, because there are many patients of torticollis we can see. Additionally, T1 slope also could be impacted also by cervical deformity reversely as a part of a compensation. So in the management of this group of patients, we should think about not only the sagittal alignment. Sometimes we also think about the torticollis. So in summary, correction of atlantoaxial dislocation with bacillation is the first option of treatment is anterior posterior approach. In our center, we prefer to use direct posterior approach as described by Dr. Goel. Quantitative correction for atlantoaxial dislocation with baseline variation based on axial tilt, but not clivaxial angle, is much more rational. The T1 slope should be another important modifier. Thank you. Thank you for your attention.